Welcome to this explainer. Today, we're cutting through the pop culture tropes and looking at exactly how modern medicine defines and diagnoses schizophrenia. We hear the word tossed around a lot in media and casual conversation, but in the clinical world, arriving at this diagnosis means navigating a very precise, rigorously tested set of criteria. So we're going to break down that exact medical framework so you can see the actual blueprints clinicians use every day. Let's get into it.
So how did doctors actually diagnose schizophrenia? Well, let's step directly into the shoes of a clinician for a minute. It's not about making some subjective guess, right? It's about following strict diagnostic rules that have literally been refined over decades of psychiatric research. And getting this right matters immensely because an accurate diagnosis changes lives. We're going to look at exactly how doctors expertly separate this condition from other mental health disorders.
Here's our roadmap for today. First, demystifying schizophrenia. Second, defining the core symptoms. Third, the DSM-5 diagnostic criteria. And finally, the ICD-11 and its evolving definition.
Okay, Part 1. Demystifying schizophrenia. Beyond the stereotypes. To really wrap our heads around this condition, we've got to leave those preconceived stereotypes at the door and start putting together the puzzle pieces that clinicians are actually looking for. You see, schizophrenia is what doctors call a heterogeneous clinical syndrome, which is just a fancy way of saying that patients can have vastly different presentations. Like two people diagnosed with schizophrenia might show completely different primary symptoms. It involves this massive range of cognitive, behavioral, and emotional dysfunctions. But here's the absolute kicker. According to the diagnostic literature, no single symptom is defining on its own. There is no one definitive giveaway. It's all about looking at the entire constellation of science. Moving right along to Part 2, defining the core symptoms, focusing on the lived experience.
Before we get bogged down in the strict clinical checklists, we really need to understand what individuals are actually going through. First up, let's talk about delusions. The clinical definition here is that these are fixed beliefs that are not amenable to change even when presented with totally conflicting evidence. We're not just talking about being stubborn about an opinion. These can be persecutory delusions, like believing you're being harmed or harassed, and those are actually the most common. Or they might be referential. Imagine genuinely, truly believing that the news anchor on your TV is blinking a secret message meant just for you. There are grandiose and somatic delusions too, but the main takeaway is the intense, unshakable conviction the person has in these beliefs, despite all evidence pointing the other way.
Next, we have hallucinations. Now, these are perception-like experiences that happen without any actual external stimulus. And it is absolutely crucial to understand something here. To the person experiencing them, these are not dreams. They aren't just an overactive imagination. They are vivid, they are crystal clear, and they have the exact full force and impact of a normal perception. The brain is processing these falsehoods as 100% real, and they are completely out of the person's voluntary control.
While a hallucination can happen with any sense, seeing or smelling things that aren't there, auditory hallucinations are by far the most common in schizophrenia. Usually, this means hearing voices. And these voices are often perceived as entirely separate from the person's own internal thoughts. They happen while the person is wide awake and fully alert. It's a profound and honestly often overwhelming lived experience that forms a massive pillar of the diagnostic criteria.
All right, Part 3. The DSM-5 diagnostic criteria, the clinical blueprint. So when we crack open the DSM-5, that's the Diagnostic and Statistical Manual of Mental Disorders, the diagnostic criteria break down into sections A through F, and you can see just how rigorous this whole thing is. It's never just a simple yes or no. It's this deep assessment of symptom presence, how long they last, the impact on everyday life, and, importantly, carefully ruling out other medical or psychiatric conditions. So let's break down the most critical parts of this framework, starting with Criterion A.
Criterion A is all about the active phase symptoms, and we've got 5 specific domains here. First, delusions. Second, hallucinations. Third, disorganized speech, which basically means frequent derailment or just incoherence in how a person is talking. Fourth is grossly disorganized or catatonic behavior. And fifth, negative symptoms. Now, negative symptoms refer to a drop or loss in normal functions, like a really diminished ability to express emotion or a volition, which is this severe lack of drive to do anything goal-directed. So the big rule here is that a patient has to show 2 or more of these 5 symptoms for a significant chunk of time during a 1-month period.
But there's a catch. We can call it the at least one rule. Even if a patient is showing disorganized behavior and negative symptoms, that alone just isn't enough. You literally cannot diagnose schizophrenia under the DSM-5 without the clear, distinct presence of at least one of the three primary psychotic symptoms: delusions, hallucinations, or disorganized speech. Basically, one of those three absolutely must be there to anchor the diagnosis.
Now, time is also a massive factor here. While those active phase symptoms we just talked about need to be present for a solid 1-month period, the DSM-5 says the continuous signs of the disturbance have to persist for at least 6 months. So that 6-month window includes the 1 month of active symptoms, but it also wraps in the milder protomal periods leading up to the episode or the residual periods that follow it. During those surrounding months, the signs might just look like negative symptoms or milder versions of the main ones, like holding some odd beliefs or having unusual perceptual experiences that haven't fully progressed into full-blown delusions or hallucinations.
You know, a reliable diagnosis is just as much about proving what the condition isn't as what it actually is. And that's where criteria D, E, and F step in. We call these the rule-outs. Clinicians have to meticulously rule out schizoaffective disorder, as well as depressive or bipolar disorders that might have psychotic features. They also need to be absolutely certain that the symptoms aren't just the physiological effects of a substance, like recreational drugs or a specific medication, or caused by another medical condition altogether. And finally, if the patient has a childhood history of autism spectrum disorder, the schizophrenia diagnosis is only added if prominent delusions or hallucinations are clearly present. This whole exhaustive rule-out process is exactly why getting to this diagnosis takes so much time and extreme care.
Okay, moving to part 4, the ICD-11 and an evolving definition.
Medical guidelines are pretty much never static, right? They're constantly being refined globally to improve precision. And one of the biggest game changers in the newly updated World Health Organization's ICD-11 is the complete removal of schizophrenia subtypes. Under the older ICD-10 system, doctors would diagnose specific variants like paranoid, hebephrenic, or catatonic schizophrenia. But the field has really shifted away from trying to force patients into those rigid little boxes. Instead, the ICD-11 uses a hybrid model that focuses on symptom and progression classifiers. It basically acknowledges that forcing a categorical subtype just isn't that accurate. By capturing the unique, dimensional elements of each person's illness, doctors get a much better baseline for treatment planning.
Because of this shift, you might be surprised to learn that the way we view catatonia has been totally reshaped. In the past, it was grouped right under schizophrenia as a specific subtype. But today, catatonia is officially recognized in the ICD-11 as its own distinct diagnostic entity. Pulling catatonia out from being purely a schizophrenia subtype recognizes a super important clinical reality. Catatonia can actually happen in a variety of other psychiatric and medical conditions. So by giving it independent status, clinicians can spot it faster across the board and jump into targeted interventions way sooner.
As we've seen today, whether we're talking about the rigorous symptom checklists of the DSM-5 or the newer subtype-free models of the ICD-11, the ultimate goal here is clarity, precision, and at the end of the day, better patient care. So I want to leave you with this final thought to ponder. As our diagnostic frameworks continue